I want you to just imagine for a moment that you're a detective. Let's call you Medlock Holmes, right?
Okay, I like where this is going.
Yeah, so you've been called in to investigate a series of, well, frankly, bizarre psychiatric reports.
Right.
You sit down at your desk, you pour yourself a coffee, and you open up the very first case file. And the patient inside describes colors that seem to be, like, alive, breathing in time with their own pulse.
Which is an incredible visual.
Oh, massively. And then you open the second file, and this patient is utterly convinced that time is just entirely frozen.
Like they're trapped.
Exactly. The clock is ticking on the wall, but they feel trapped in this single, infinite second. Then the third file describes this sensation of being completely detached from their own physical form.
Right, hovering somewhere near the ceiling.
Yeah, literally looking down at their own hands.
Yeah.
And then a fourth speaks of this overwhelming, almost unbearable sense of universal empathy, like profound love for complete strangers.
And then there's the fifth case.
Right. The fifth is, well, they're experiencing terrifying paranoia, dodging geometric trails in their vision long after a weekend party has ended.
It's a pretty remarkable set of case files to land on your desk.
Yeah.
And I mean, if you're sitting in an emergency department or a psychiatric clinic and you're just looking at these presentations in a vacuum,
Yeah.
every single one of those cases appears to point towards severe organic mental illness.
Absolutely.
You'd be completely forgiven for thinking you're looking at acute psychosis or a severe manic episode, or maybe even a profound trauma-induced dissociative disorder.
Because the symptoms map onto our standard psychiatric categories almost perfectly at first glance.
We really do.
But you, as Medlock Holmes, you start looking for the thread. You notice this crucial unifying clue across every single file.
The exposure.
Exactly. These experiences, as varied as they are, all follow a recent exposure to a specific class of substances. Substances that are capable of just profoundly altering human consciousness.
Which, brings us to the anchor for our entire discussion today. Psychiatry, at its core, isn't just the study of illness.
Right.
It's the study of how the brain, the mind, and human experience interact. And crucially, how that intricate process can go wrong. Or, well, simply go differently.
Which is why today we're exploring a category of substances that artificially manipulate that very interaction. And they do it in ways that are entirely unique compared to almost anything else we ingest.
Absolutely.
So we're using Chapter 11.6 of Kaplan and Sadok's Comprehensive Textbook of Psychiatry as our spine today. We're focusing on hallucinogen-related disorders.
But to be clear to you listening, we aren't just going to sit here and read you the textbook.
No, definitely not.
Our mission today is to build your mental models, to really clarify the neurobiological mechanisms at play, and, well, to strengthen your clinical reasoning.
We want to get under the hood of how psychiatrists actually think about these altered realities.
Because the central paradox of hallucinogens is just absolutely fascinating. I mean, think about other psychoactive substances for a second.
Like alcohol or sedatives?
Right. Alcohol, heavy opioids, benzodiazepines. By and large, they cloud consciousness.
They dull things down.
Exactly. They sedate, they induce delirium, they dull the sensorium. Basically, the more you take, the less aware you become.
Right.
Hallucinogens are the striking exception to this rule. They profoundly alter perception, emotion, and the sense of self, but, and this is key, they generally leave consciousness itself perfectly intact.
That is such an important distinction. They don't just intoxicate the user, they fundamentally reshape how the user experiences reality.
All while that person remains completely awake and aware.
I want to pause on the nomenclature here for a second because calling them hallucinogens, which I know is the official DSM-5-TR standard, it feels like a bit of a trap.
Oh, it is.
It's actually a massive misnomer, isn't it?
It absolutely is, and it causes a lot of clinical confusion because the term hallucinogen implies that these drugs primarily produce strict hallucinations. But in psychiatry, a true hallucination is perceiving something that is completely absent from reality, without any external stimulus.
Like hearing a distinct voice when you are completely alone in a silent room?
Spot on. In truth, these substances mostly produce illusions.
Okay, so just to clarify for everyone, an illusion is a distortion of something that's actually there.
Yes, it's a misinterpretation of a real sensory stimulus. So, you look at a real brick wall, but the mortar between the bricks appears to be melting. or flowing like a river.
So the wall is real, it's there.
Exactly. The wall is there. The perception of it is just heavily distorted. And because of this inaccuracy, there's a really vigorous debate in the medical community about what we should actually call these compounds.
And the alternatives tell quite a story about how different groups view them, right? Like you hear psychedelics, which literally translates to mind manifesting.
Right, from the Greek.
Yeah. Then there's dissociatives, which speaks to that detachment from the body we mentioned in the case files earlier.
Or intoxications.
Yes. Or empathogens, meaning touching within, which relates to that feeling of universal love.
And even entheogens.
Right, which refers to generating the divine, usually referring to plant medicines used in a spiritual or, a ritualistic context.
But the DSM-5-TR sticks with hallucinogens as the official umbrella term, largely for historical continuity. But as clinicians, we have to recognize how vast and heterogeneous that umbrella truly is.
Because we're grouping together naturally occurring plants, semi-synthetic laboratory creations, and purely synthetic compounds.
All with entirely different mechanisms of action in the brain, so treating them as a single monolith is clinically dangerous.
Totally. And to understand why they're grouped this way, we really have to look at the shifting cultural lens. The historical context of these substances is wild.
It really is.
I mean, humanity's relationship with these compounds goes back millennia. We're talking ancient indigenous ritualistic use.
Ayahuasca ceremonies in the Amazon basin.
Exactly. And peyote use among indigenous groups in North America. But in Western medicine, the story really kicks off in a Swiss laboratory in 1943, doesn't it?
Yes, the famous story of Albert Hofmann, a chemist at Sandow's laboratories.
The bicycle ride.
Right, the bicycle day.
Yeah.
He accidentally synthesized and then, ingested a minuscule amount of lysergic acid diethylamide, LSD.
And prior to that fateful bicycle ride home from his lab, modern science really had no known compounds that could produce such profound alterations in cognition at those doses.
Right, sub-milligram doses. We're talking about doses measured in micrograms. It was an absolute paradigm shift for pharmacology.
And the psychiatric community in the 1950s just sort of lost their collective minds over this in a professional sense.
Oh, they were fascinated.
They jumped on this idea of the model psychosis because they were desperately searching for biological explanations for severe mental illnesses like schizophrenia.
Which at the time was heavily blamed on, poor parenting or subconscious conflicts, Freudian concepts.
Right, the schizophrenogenic mother theory, which was so damaging.
Terribly damaging. So the logic at the time with LSD seemed sound, if simplistic. Sandoz actually encouraged psychiatrists to take LSD and mescaline themselves.
Wow, just to understand their patients.
Exactly. And when these doctors experienced profound perceptual shifts, paranoid thoughts, and disorganized thinking on LSD, they hypothesized that schizophrenia might be caused by an endogenous compound.
Like something the brain makes naturally.
Right. That is chemically similar to LSD. The theory was, if we can study a drug-induced model psychosis in healthy volunteers, we can finally understand and cure schizophrenia.
But that theory completely fell apart. I mean, why did highly trained psychiatrists think a visual trip was the exact same thing as schizophrenia?
Because they were focusing primarily on the acute positive symptoms.
The loud stuff.
Exactly, the most dramatic visible signs of psychosis. And they were completely ignoring the rest. The clinical reality of schizophrenia does not match a classic psychedelic trip.
Right.
True schizophrenia features prominent negative symptoms: severe apathy, flattened affect, social withdrawal, poverty of speech.
And the positive symptoms are different too, aren't they?
Massively. The positive symptoms of schizophrenia are most characteristically auditory hallucinations and deeply entrenched, bizarre delusions.
Whereas classic hallucinogens like LSD are doing something completely different.
Yes, they primarily produce visual illusions. And the most critical difference, Medlock, is that LSD preserves insight.
That's the key.
A person on LSD generally knows they have taken a drug. They know the melting wall is a product of chemistry.
But a patient suffering from schizophrenia fundamentally believes their delusions and hallucinations are reality.
The insight is shattered.
So the history of hallucinogens in psychiatry is basically this massive pendulum.
That's a good way to put it.
It swings all the way to miracle research tool in the 1950s. Then the cultural explosion of the 1960s happens, the drugs escape the lab, and they become heavily associated with the counterculture.
And the establishment pushes back.
Hard. The pendulum swings back to societal menace, leading to sweeping criminalization in the 1970s. Research essentially just grinds to a halt for decades.
Yeah. And now, today, the pendulum is swinging back to the middle, We're in this renaissance of viewing them as carefully controlled clinical tools.
Which is very exciting. We have esketamine approved for treatment-resistant depression and MDMA and psilocybin in advanced clinical trials for PTSD and depression.
And alongside this clinical renaissance, we are seeing a massive epidemiological shift in the general public, aren't we?
We are. According to the National Survey on Drug Use and Health, about 16% of Americans over the age of 12 have used a hallucinogen in their lifetime.
16%. That's huge.
It makes it the fourth most commonly used class of illicit drugs in the U.S., sitting only behind cannabis, opioids, and stimulants.
And we really can't talk about modern use without bringing up microdosing. I mean, it's everywhere.
Oh, it's ubiquitous in certain circles.
Tech CEOs, artists, students taking these sub-perceptual doses, usually a tenth of a standard dose of LSD or psilocybin. And the claim is that it boosts creativity, cures depression, and increases focus without any trippy effects. It's highly prevalent. But this brings us to a fascinating intersection of pharmacology and psychology, the battle between evidence and expectation.
Okay, tell me more.
Recent, rigorous, placebo-controlled trials of microdosing have largely failed to identify objective, measurable benefits compared to a placebo.
Wait, really? So the reported benefits are just in people's heads?
To a large extent, yes.
Yeah.
A major 2021 prospective study found that the reported benefits of microdosing were heavily predicted by the user's positive expectations.
The placebo effect.
Exactly. If they believed they were taking a microdose and they expected to feel more creative, they reported feeling more creative even if they had been given a placebo pill.
That is wild.
It is a powerful demonstration of the expectancy effect. The ritual and the belief are doing the heavy lifting rather than pure pharmacology.
That's so interesting. But I want to push back on the danger aspect for a moment, just playing devil's advocate here.
Sure.
If 16% of the population has tried these substances, and as population-level studies consistently show, there is no broad association between lifetime serotonergic hallucinogen use and negative mental health outcomes like long-term psychosis or depression.
Right.
Are we as a medical community overstating the psychiatric danger? It sounds like statistically most people are absolutely fine.
It's a vital point to raise, and one that requires a lot of nuance. Population studies tell us about broad statistical trends. They average out the data.
Right. They look at the big picture.
And they do suggest that for the vast majority of the population, these substances do not trigger lasting psychiatric illness. However, population safety does not negate individual vulnerability.
Ah, okay. So the statistics essentially hide the outliers.
Exactly. A 1% or 2% risk of a catastrophic psychological break might just vanish in a massive population-level regression analysis.
But it doesn't vanish for that one person.
Exactly. If you are the clinician in the emergency department treating that one individual whose underlying latent psychotic disorder was violently unmasked by a hallucinogen, the danger is entirely real. We treat individuals, not populations.
That makes perfect sense, and that perfectly bridges us into the mechanism of action. Because to understand that individual vulnerability, we have to understand the actual architecture of these altered states.
We need to break down this massive, misleading hallucinogen umbrella into its distinct neurobiological classes.
And I've been trying to picture how this all works in the brain, and I keep coming back to a massive mixing board in a recording studio.
Oh, I don't like that.
You have all these different faders and dials for sensory input, memory, emotion, and pattern recognition, and different classes of hallucinogens are just sliding entirely different sets of faders up and down.
That is a brilliant analogy. Let's map out the mixing board then. The first major group we need to look at are the NMDA receptor antagonists,
Commonly known as the dissociatives.
Right. This group includes phencyclidine, or PCP ketamine, and dextromethorphan, or DXM, which is actually the active ingredient in many over-the-counter cough syrups.
All right, so if I'm taking a dissociative, what fader am I pulling on the mixing board?
You are primarily pulling down the fader for the N-methyl-D-aspartate, or NMDA, receptor.
Pulling it down? Oh.
Yes. These drugs act as non-competitive antagonists at this receptor, which is a major excitatory receptor in the brain.
So it's blocking the excitement.
By blocking it, they decrease the influx of calcium and sodium ions into the neuron. But the brain is a highly interconnected system. Blocking this receptor doesn't just turn everything off. It creates a cascade.
A ripple effect.
Exactly. The downstream effect of this blockade leads to a massive secondary release of glutamate in the prefrontal cortex and a significant release of dopamine in the mesolimbic pathway.
So we are pulling down the primary sensory input fader, but we are simultaneously boosting the dopamine fader in the reward center.
Yes.
How does that actual chemical cascade manifest in the patient sitting in front of you?
Subjectively, it manifests as a profound sense of mind-body separation. Dissociation.
Hence the name.
Exactly. The sensory input from the body isn't integrating correctly with the conscious mind. Crucially, though, these patients maintain their airway reflexes.
Oh, right, which is why ketamine is such a valuable anesthetic in emergency medicine and pediatrics.
Spot on. They keep breathing on their own. But psychologically, they experience significant cognitive impairment, depersonalization, and potentially severe disorganized thought disorders.
You mentioned earlier that the 1950 psychiatrists were wrong to use LSD as a model for schizophrenia. Does that mean there is a better model?
Yes, PCP and ketamine actually provide a much more accurate pharmacological model for schizophrenia.
Why is that? I mean, why does pulling the NMDA fader look more like schizophrenia than pulling the serotonin fader?
Because NMDA antagonism mimics the symptoms of thought disorder and the negative symptoms much more closely.
The apathy and withdrawal we talked about.
Right. PCP induces withdrawal, negativism, blunted affect, and sometimes even catatonia. Furthermore, both PCP and ketamine inhibit something called prepulse inhibition.
Okay, let's unpack prepulse inhibition. What is that practically?
Think of it as the brain's sensory filtering system. Imagine you are walking in the woods in absolute silence,
Okay, I'm in the woods.
and suddenly a massive branch snaps directly behind you. You would startle violently. That's a normal reflex.
Yeah, my heart would jump out of my chest.
But if you hear a tiny rustle of leaves just a split second before the branch snaps, your brain uses that small pre-stimulus, the prepulse, to anticipate the loud noise.
And so I don't jump as high.
Exactly. Your startle reflex is significantly dampened.
Yeah.
Your brain filters the input.
It braces for impact.
Precisely. Now, in patients with schizophrenia, this filtering system is broken. They lack prepulse inhibition,
So every sound is the loud branch snapping.
meaning they are constantly bombarded by sensory information without the ability to filter or anticipate it. And PCP and ketamine artificially break this exact same filtering system in healthy individuals.
That makes total sense. All right, so that's the dissociative side of the mixing board. Let's slide over to the serotonergic classic hallucinogens.
The ones most people think of.
Yeah, this is the group most people picture when they hear the word psychedelic. We have LSD, which is structurally an ergoline, psilocybin and DMT, which are tryptamines, and mescaline, derived from peyote, which is a phenylcalamine.
Now, despite their structural differences, they look very different on a molecular level, they all share a primary mechanism of action.
Which is?
They act as agonists, or partial agonists, at the serotonin 2A, or 5-HT2A receptor.
So they were cranking up the serotonin 2A fader. What does that actually do to the audio mix of the brain?
It radically alters the signal-to-noise ratio in the visual cortex and the prefrontal cortex. It turns up pattern recognition and emotional resonance to 11.
Which results in the classic psychedelic effects.
Exactly. Altered shapes, intensification of colors, and synesthesia.
That's the crossing of sensory wires, right?
Right, that fascinating phenomenon where a patient might literally see music as visual shapes or taste colors. It also induces profound emotional ability.
And this is where we have to talk about set and setting. Because with this specific class of drugs, the environment seems to matter almost as much as the dose itself.
It is the most critical variable. Because 5-HT2A agonism amplifies internal emotional states and heightens sensitivity to environmental inputs, the pharmacology almost takes a back seat to the psychology of the user.
Wow.
The patient's mindset going into the experience, the set, and their physical, social, and cultural environment, the setting, largely dictate the outcome.
So a warm, supportive environment with a positive mindset might produce this transcendent therapeutic experience.
Yes, but taking the exact same dose in a chaotic, hostile environment while feeling anxious, that can precipitate a terrifying panic attack, or what we commonly call a bad trip.
I have a specific question about the mechanics here. If LSD and psilocybin both hit the exact same 5-HT2A receptor, why do users report the trips feeling so fundamentally different? And why does tolerance to these specific drugs build up so incredibly fast? Like, you can't just take LSD every day.
Right. Well, the subjective differences are likely due to the fact that these drugs don't only hit the 5-HT2A receptor, they have varied receptor affinities across the wider serotonin system.
Like other receptors, too.
Yeah, 5-HT1A, 5-HT2C, and so on, as well as distinct pharmacokinetics. LSD lasts 8 to 12 hours, psilocybin lasts 4 to 6. That duration entirely alters the psychological arc of the experience.
Right. And what about the tolerance?
The rapid tolerance is known as tachyphylaxis, and it's a defining feature of classic hallucinogens. If you take a dose of LSD today, taking the exact same dose tomorrow will have a vastly diminished effect.
And the next day?
Take it the third day, and you might feel almost nothing.
So the brain is just actively shutting the doors?
Literally, yes. The brain rapidly downregulates and internalizes the 5-HT2A receptors on the surface of the neurons.
It pulls them inside the cell.
It pulls them inside to prevent them from being overstimulated. It's a rapid protective mechanism.
That's brilliant.
The good news is that it reverses completely after about a week of abstinence.
All right, let's move to the third major group on the board, the entaptogens. This is primarily MDMA, known on the street as ecstasy or Molly.
And MDMA functions entirely differently from the classic psychedelics. Its primary mechanism is inducing a massive release of endogenous serotonin from presynaptic stores while simultaneously inhibiting its reuptake.
So it's forcing the brain to dump all its serotonin reserves into the synapse and then preventing it from being cleared away.
Exactly. It also has mild dopaminergic and noradrenergic stimulant effects and some mild 5-HT2A stimulation.
So we are pushing the serotonin release fader to the absolute maximum. And the manifestation here is that overwhelming feeling of emotional closeness, empathy, and acceptance combined with physical energy.
Right. It doesn't typically cause the melting walls or massive visual distortions of LSD.
Right. It's more emotional.
It enhances prosocial behavior, which is likely mediated by downstream oxytocin release, which is why it is showing such profound efficacy in clinical trials for PTSD.
Because it lowers fear.
It lowers the fear response in the amygdala while maintaining a perfectly clear sensorium.
Now, beyond these three main groups, we have some fascinating outliers that just defy simple categorization. Ibogaine, for example, an alkaloid from West Africa.
Ibogaine is incredibly complex. It acts on multiple receptor systems simultaneously: serotonin, NMDA, opioid, and cholinergic pathways.
All at once.
All at once. It produces an intensely long-lasting, physically grueling, and sometimes deeply distressing experience that can linger for days.
But it's used for addiction treatment sometimes, right?
It has gained a lot of attention for its potential to interrupt opioid addiction, though its cardiac risks are quite significant.
Then there is salvinorin A, which is the active compound in the salvia plant.
Yes, which is highly unique because it doesn't interact with the serotonin system at all.
Oh, really?
It is a highly potent, selective agonist at the kappa opioid receptor.
Now, most people hear opioid and think of morphine and euphoria, but that's the mu opioid receptor, right? What does the kappa receptor do?
Well, the kappa opioid receptor is often thought of as the anti-reward receptor.
Anti-reward. Sounds awful.
It is. Modulating it produces dysphoria, intense dissociation, and a feeling of altered gravity or like physical folding. Salvinorin A produces an extremely brief, perhaps 10 to 15 minute, but absolute break with reality.
Wow.
Often involving profound disorientation and impaired recall of the event.
And finally, the drugs that don't just adjust the mixing board, but essentially spill a drink on the motherboard entirely. The anticholinergic deliriants like datura or Jimson weed.
These are muscarinic receptor antagonists. They block acetylcholine, which is a critical neurotransmitter for memory and cognitive function.
So what happened?
Unlike the other substances we've discussed, these produce true hallucinations. Talking to people who aren't there, smoking imaginary cigarettes alongside profound disorientation, memory impairment, and a fluctuating level of consciousness.
So they induce a true medical delirium.
They do. They are neurotoxic and incredibly dangerous.
Before we leave pharmacology entirely, I really want to circle back to DMT because the neurobiology of ayahuasca is just mind-blowing.
It's fascinating.
It's a perfect example of ancient ethnobotanical science. I mean, if I just eat pure DMT powder, nothing happens.
Right, that is correct. DMT is orally inactive. If consumed orally, DMT is rapidly destroyed in your gut and liver by an enzyme called monoamine oxidase A, or MAOA.
Let's use an analogy here. The MAOA enzymes are basically bouncers at the club of your bloodstream, and DMT is on the banned list.
I love that.
The moment DMT shows up in the gut, the bouncers tackle it and break it down. It never reaches the brain.
That's exactly right. But the indigenous peoples of the Amazon basin figured out a biochemical hack centuries ago.
Which is just incredible.
The ayahuasca brew brilliantly combines a DMT-containing plant, usually Psychotria viridis, with a specific vine called Banisteriopsis caapi.
And the vine doesn't have DMT.
No, the vine doesn't contain DMT. It contains harmala alkaloids, which are potent monoamine oxidase inhibitors, or MAOIs.
So the vine essentially distracts or disables the bouncers.
Yes. By inhibiting the MAOA enzyme in the gut, the MAOI renders the DMT orally active. The bouncers are tied up, allowing the DMT to cross into the bloodstream, reach the brain, and produce a profound, hours-long psychedelic experience.
It is a remarkable piece of synergistic pharmacology developed long, long before we knew what an enzyme was.
Absolutely brilliant.
And here is where it gets really interesting for those of us focused on addiction psychiatry. Why aren't classic psychedelics like LSD and psilocybin addictive?
It's a great question.
I mean, you see monkeys and rats in laboratory settings pressing levers until they die of exhaustion for cocaine, heroin, or PCP. But if you put LSD in the lever, they won't self-administer it. They actually avoid it.
This is a crucial clinical distinction. The DSM-5-TR makes it clear that classical drugs of abuse generally activate the brain's dopaminergic reward systems, primarily the ventral tegmental area and the nucleus accumbens.
Right, the reward loop.
Classic hallucinogens do not reliably do this. In fact, one heavily theorized explanation centers on their interaction with a different serotonin receptor, the 5-HT2C receptor.
What does the 2C receptor do?
In preclinical models, 5-HT2C receptor agonism actually opposes the reinforcing potential of addictive compounds.
It opposes it.
Yes, it modulates and inhibits dopaminergic activity in those core reward pathways.
So by hitting the 5-HT2C receptor, psychedelics are actively putting the brakes on the addiction circuitry.
Exactly. Contrast this with PCP, ketamine, and MDMA. Those substances do trigger the dopaminergic reward pathways.
Which is why they carry a liability for dependence.
Right. A moderate to high liability for dependence and compulsive use. The pharmacology predicts the behavioral pathology.
All right, Medlock Holmes, we have the suspects and their MOs. Now let's leave the theory behind and walk into the emergency department on a Saturday night.
Okay, let's do it.
We are moving from intoxication to toxicity. A patient is brought in by paramedics. They are highly agitated, hallucinating, and tachycardic. The nurses are asking for a full tox screen, but we know that takes hours or days to come back. How does a psychiatrist triage this instantly?
You don't wait for the tox screen. You have to act fast. And your best diagnostic tool is a rapid, focused physical examination, specifically looking for autonomic nervous system signs.
Right.
You must check the eyes, the skin, and the vital signs.
Walk us through the clinical decision tree. Let's start with the dissociatives, PCP, and ketamine. What are the red flags?
If a patient is intoxicated with PCP or ketamine, you will see a classic dissociative state. They might seem entirely detached from reality, staring blankly. Crucially, look closely at their eyes for nystagmus.
Which is involuntary rapid eye movements.
Yes. Specifically, look for rotary nystagmus.
What does rotary nystagmus actually look like to the person examining them?
Instead of the eyes just darting horizontally from left to right, the eyeball actually rolls or twitches in a circular motion,
Like a circle.
almost like a broken gyroscope trying to find its balance. Rotary nystagmus is a highly specific clinical sign for NMDA antagonist intoxication, particularly PCP.
So, rotary nystagmus equals PCP or ketamine until proven otherwise.
Yes. Alongside that, you will see hypertension, ataxia, which is severe incoordination, and a markedly diminished response to pain.
Oh, because they're dissociated.
This combination is why PCP intoxication can be so profoundly dangerous for first responders and staff. The patient may exhibit extreme, unpredictable violence, and because they are dissociated, they feel absolutely no pain when restrained.
That's a terrifying combination.
Ketamine is generally less malignant, but PCP can rapidly escalate to seizures, severe hyperthermia, and hypertensive crisis.
Okay, different patient. What if you shine a light in their eyes and you see massive pupillary dilation, mydriasis, but there is absolutely no nystagmus?
Then you are likely looking at a serotonergic agent. If it is a classic hallucinogen like LSD or psilocybin, you will see that massive mydriasis and perhaps mild tachycardia. But the physiological effects are generally mild.
So their heart rate is a bit up, but they're relatively stable.
The patient might be terrified, experiencing a panic attack or a bad trip, but their vital signs are relatively stable. The emergency is psychological, not physiological.
But what if they have those dilated pupils and they are burning up? Like they are sweating profusely, their heart is racing, and their jaw is clenched so tight they might crack a tooth.
Now you are dealing with MDMA, and the situation is critical. You must be highly vigilant for impending serotonin syndrome.
Which is life-threatening.
MDMA toxicity is incredibly dangerous. It can cause severe hyperthermia, body temperature spiking to lethal levels. This leads to profound muscle rigidity, which in turn causes rhabdomyolysis.
Let's explain rhabdomyolysis for the listeners who might be a bit rusty on their internal medicine.
When muscles become that rigid and hyperthermic, the muscle tissue actually begins to break down and die. As the muscle fibers break down, they release a protein called myoglobin into the bloodstream.
And where does that go?
These large proteins travel to the kidneys and essentially clog the filtration system, leading rapidly to acute renal failure.
And there is a specific pharmacokinetic trap with MDMA that clinicians really need to understand because it explains why patients suddenly crash.
Yes, MDMA has nonlinear pharmacokinetics. MDMA actually inhibits its own metabolism via the liver enzymes CYP2D6 and CYP3A4.
Hold on, that's a bit of alphabet soup. Let's translate that back to our bouncer analogy.
Fair enough. Think of CYP2D6 as the specific bouncers in the liver assigned to escort MDMA out of the body.
Okay, they're the exit bouncers.
When a user takes their first pill of MDMA, the bouncers go to work. But MDMA is tricky. It actually binds to the bouncers and incapacitates them.
It takes them out.
So an hour later, the user feels fine, maybe the high's wearing off, and they take a second pill.
But there are no bouncers left to clear the second pill.
Exactly. Because the first dose incapacitated the metabolic enzymes, that second dose isn't broken down at a normal rate. It causes a massive exponential spike in blood levels.
So it's not 1 + 1 = 2.
It is not a linear dose response. 1 + 1 might equal 10 in terms of blood concentration. It is a rapid, unpredictable escalation to toxicity.
There is also a specific, very dangerous risk for female patients with MDMA, right?
Yes, MDMA can cause severe hyponatremia, which is dangerously low sodium levels in the blood.
How does that happen?
MDMA triggers the inappropriate release of antidiuretic hormone, ADH, which tells the kidneys to stop producing urine and retain water.
And if they're at a rave?
Combine this with a patient who is at a rave, dancing, sweating, and compulsively drinking massive amounts of water to stay cool. They are retaining all that water, which dilutes the sodium in their blood.
Which is very bad for the brain.
This can lead to cerebral edema, swelling of the brain, and fatal seizures. And statistically, this complication occurs much more frequently in young females, likely due to differences in baseline hormone levels and body mass.
What about the new synthetic stuff, like the research chemicals that kids are buying online?
Novel psychoactive substances like the embiomes or bromodragonFLY are terrifying from a clinical perspective.
Because they're sold as LSD, right?
They're often sold on blotter paper and passed off as LSD, but their pharmacology is very different.
Yeah.
Classic LSD is only a partial agonist at the 5-HT2A receptor. It only turns the dial up partway.
Right.
The embiomes are highly potent full agonists. They turn the dial until it breaks off.
So the effects are exponentially stronger.
Vastly more toxic.
Right.
They don't just cause hallucinations. They can cause severe systemic vasoconstriction, cutting off blood supply and leading to tissue necrosis.
Oh, wow.
They cause prolonged delirium, requiring intensive care, severe seizures, and fatal cardiac events. If a patient says they took a normal dose of LSD but they're having seizures, you must suspect an embiome.
And finally, going back to triage, what if the patient is dry as a bone, red as a beet, and blind as a bat?
That is the classic medical mnemonic for anticholinergic toxicity. Jimson weed or datura. Because acetylcholine is blocked, the parasympathetic nervous system is shut down. No sweating dry as a bone. Flushed skin red as a beet. Massive pupil dilation causing blurry vision, blind as a bat. And true, profound delirium, mad as a hatter.
So, management strategies. How do we treat these different toxidromes?
For PCP and MDMA toxicity, the focus is aggressive medical management. For MDMA, you need aggressive, rapid cooling for the hyperthermia and aggressive intravenous fluids to flush the kidneys and prevent rhabdomyolysis from causing renal failure.
And for the agitation?
Benzodiazepines are the absolute frontline treatment for agitation, hypertension, and seizures in both PCP and MDMA cases.
And for the classic hallucinogens, where the emergency is mostly psychological?
The intervention is mostly supportive, talking down the patient in a quiet, safe, low-stimulus environment.
Just keeping them calm.
Reassurance is key. You remind them that they took a drug, that they are safe, and that the feeling will pass. Benzodiazepines can be used if the anxiety is severe or refractory to verbal de-escalation.
What about for anticholinergic delirium?
It is mostly supportive care and benzodiazepines for agitation. There is an ongoing controversy regarding the use of physostigmine.
Why is it controversial?
Well, physostigmine directly reverses the anticholinergic effect, which sounds great in theory. But it should only be reserved for cases where it is definitively 100% clear that only anticholinergics have been ingested.
Which is hard to know in the ED.
Exactly. If the patient has mixed drugs in their system, physostigmine carries significant cardiac risks and can precipitate fatal arrhythmias.
Okay, let's say the acute crisis has passed, the drug has cleared their system, the patient goes home. But for some patients, the story doesn't end there.
No, it doesn't.
Let's move to the long-term sequelae and psychiatric integration. First off, how do we define hallucinogen use disorder?
The DSM-5-TR criteria for hallucinogen use disorder apply, much like they do for other substances, impairment in social functioning, dangerous use, craving, but with one massive exception.
A withdrawal.
Right. There is no recognized withdrawal criterion for hallucinogens. While MDMA and PCP can produce some physical dependence and withdrawal syndromes, the classic psychedelics do not.
So, if there is no physical withdrawal, what drives the disorder? Why do people keep using to the point of ruining their lives?
Item response theory studies, which analyze how people answer questionnaires about their drug use, show that users rarely lose control over the amount they take.
They aren't binging it.
They don't typically binge hallucinogens compulsively for days, like one might with alcohol or crack cocaine. The disorder usually stems from continued use despite severe social, occupational, or psychological consequences.
Right.
They are using because they highly value the psychological effects, the escapism or the altered state, not because they are physically compelled to stave off withdrawal symptoms.
Which brings us to one of the most fascinating and distressing long-term sequelae HPPD, or hallucinogen persisting perception disorder. I was trying to explain this to a medical student recently, and I likened HPPD to screen burn-in on an old plasma TV. The movie is over, you have turned off the DVD player, but the ghost of the menu image is still permanently burned into the screen, disrupting whatever you try to watch next.
That is a very accurate way to visualize it, and it captures the distress it causes. Patients with HPPD re-experience perceptual effects, geometric trails following moving objects, halos around lights, macropsia, where objects appear much larger than they are long after the drug has cleared their system.
Sometimes months or years later.
Yes.
And it's not all the same, right? There are subtypes.
We now differentiate between type A, which are benign, brief flashbacks. They might happen occasionally, and they might not even be distressing to the patient.
And type 2?
Type 2, however, is a chronic, persistent visual dysregulation that is constantly present and causes immense clinical distress.
What is actually happening in the brain to cause this permanent burn-in?
The pathophysiology isn't entirely settled, but the leading theory implicates potential neurotoxic damage or long-term downregulation of lower-level visual system inhibitory cortical interneurons.
Let's break that down a bit.
In your visual cortex, you have specific neurons that act as a filter. They express 5-HT2A receptors and release GABA, which is an inhibitory neurotransmitter. Their job is to quiet down visual static.
That they keep the picture clear.
If these specific neurons are damaged or dysregulated by a massive dose of a hallucinogen, it alters the baseline signal-to-noise ratio in the visual cortex. Essentially, the brain loses its ability to filter out everyday visual noise.
The clinical nuance here is fascinating. A patient comes to your clinic terrified because they are seeing trails behind moving cars and geometric patterns on blank walls. But the very fact that they are telling you this and that they know it shouldn't be happening is the most crucial diagnostic clue you have.
Exactly. Intact insight. The fact that they know the trails aren't real and that they are distressed by them proves they are not suffering from a primary psychotic disorder like schizophrenia.
A patient with schizophrenia would likely incorporate those visual trails into a delusion.
Yes. The HPPD patient knows it's a visual glitch. However, that intact insight often generates massive secondary anxiety and depression because they feel their perception is permanently broken.
What about when the insight is lost? What about hallucinogen-induced psychotic disorder?
This is a psychotic episode triggered by the drug that significantly outlasts the intoxication phase. The drug is gone, but the psychosis remains.
How does it differ from schizophrenia?
Compared to primary schizophrenia, these substance-induced psychoses usually present in younger patients, and they often feature strong affective or mood components, things like mania, grandiosity, and hyperreligiosity, rather than the flat effect and withdrawal we see in schizophrenia.
Which brings me to a classic psychiatric chicken or egg question.
Yep.
Say you have a 19-year-old, they have a strong family history of schizophrenia, but they've been perfectly fine. They take a heavy dose of PCP, and they spiral into a psychotic break that never really resolves. Was it the PCP that broke their brain, or were they going to break anyway?
If we connect this back to our anchor, how brain, mind, and experience interact, we rely on the diathesis stress model.
Right, the vulnerability.
The patient has a diathesis, an underlying, perhaps genetic, biological vulnerability to psychosis.
Sure.
The drug, especially an NMDA antagonist like PCP, which we know perfectly models schizophrenic pathology, acts as a profound environmental stress.
So it's the trigger.
The PCP unlocks the vulnerability. Without the drug, they might have never transitioned to active psychosis or might have happened 5 years later. The drug is the catalyst that triggers the underlying architecture of the illness.
Finally, before we wrap up the long-term effects, we have to touch on neurotoxicity. Do these drugs physically damage the brain?
It depends entirely on the class. There is fairly consistent evidence, particularly from animal models and some human imaging studies, that extensive heavy use of MDMA is neurotoxic.
Yeah.
It can lead to long-term serotonin transporter depletion and potential neurocognitive deficits, specifically in memory and executive function.
And the dissociatives.
Heavy, chronic PCP and ketamine use can also cause significant memory and executive function deficits, as well as severe bladder toxicity in the case of ketamine.
With the classic hallucinogens, the LSDs and psilocybins.
In contrast, there is currently no robust evidence of structural neurotoxicity with classic hallucinogens. Studies of indigenous groups with long-term ritualistic lifetime use of peyote or ayahuasca have not revealed long-term neurocognitive impairment compared to matched controls.
Okay, let's step back and look at the whole board. If we distill this vast chapter down, what are the core truths that our detective, Medlock Holmes, has uncovered?
First, the defining trait of hallucinogens is their unique ability to profoundly alter reality and the sense of self without inducing delirium or clouding consciousness.
That's key.
Second, clinicians must recognize the pharmacological split. Treating an NMDA antagonist dissociative like PCP is entirely different from treating a serotonin-releasing antagogen like MDMA.
Right.
Third, the paramount importance of set and setting in dictating the subjective experience of classic psychedelics. And finally, the critical clinical red flags for rapid triage rotary nystagmus for dissociatives and severe hyperthermia for MDMA.
Which leaves us with a provocative thought to mull over. As we sit here today, psychiatry is on the precipice of prescribing these exact same substances to treat the very disorders we once feared they caused.
We are.
We're looking at prescribing MDMA for severe PTSD and psilocybin for treatment-resistant depression.
It raises perhaps the most important philosophical and clinical challenge of our time in psychiatry. How will we redraw the line between a toxic substance-induced altered state and a therapeutic psychiatric intervention?
Because the molecule is the same.
The molecule itself remains exactly the same. The 5-HT2A receptor does not know if it is in a sterile clinical trial or at a muddy music festival. Only our clinical intent, the psychological preparation of the patient, and the safety of the environment have changed.
It all comes back to the muddy waters of the diagnosis and the human element. The MRI machine cannot help us here. It requires clinical reasoning.
Absolutely.
All right, it is time for our learning reinforcement section. We are going to run through a single best answer, or SBA, section to lock in those mental models. I will read the clinical scenario, we'll give you a beat to think, and then our expert will reveal the answer and the why based on the text.
Sounds good.
Question 1. A 22-year-old male is brought to the ED by police. He is highly agitated, seemingly impervious to pain while being restrained, and exhibiting prominent rotary nystagmus. What mechanism of action is most likely responsible for his state?
Just take a second to think about that.
All right, what's the answer?
The answer is non-competitive NMDA receptor antagonism. The presentation of severe agitation, analgesia, and crucially, rotary nystagmus is the classic clinical picture for PCP intoxication.
Spot on. Question 2. A female patient presents to the emergency department with acute hyperthermia, muscle rigidity leading to suspected rhabdomyolysis, and severe jaw clenching after attending an electronic music festival. Which substance is the most likely culprit, and what is its primary neurotransmitter effect?
We'll give you a moment.
Okay, let's hear it.
The answer is MDMA. Its primary neurotransmitter effect is serotonin release and reuptake inhibition. The clinical triad of profound hypothermia, muscle breakdown, and bruxism in a party setting is highly specific to MDMA toxicity and impending serotonin syndrome.
Question 3. Which specific receptor interaction is theorized to explain why classic hallucinogens like LSD and psilocybin do not typically produce true addiction or compulsive self-administration in animal models?
Have a think.
And the answer?
The answer is 5-HT2C receptor agonism. Stimulation of this specific serotonin receptor subtype appears to modulate and oppose the dopamine reward pathways in the ventral tegmental area and nucleus accumbens, preventing the reinforcement loop seen with classical drugs of abuse.
Brilliant.
Yeah.
Question 4. A patient reports seeing trails behind moving objects and geometric patterns on blank walls weeks after using a high dose of LSD. Crucially, they are highly distressed by these images because they know they are not real. What is the most accurate diagnosis?
Take a mead.
Go ahead.
The diagnosis is hallucinogen persisting perception disorder, or HPPD. Because the patient has preserved insight, they know the visual distortions are not reality. This definitively rules out a primary psychotic disorder.
Question 5. Why is the traditional ayahuasca brew orally psychoactive, whereas pure DMT consumed orally is entirely inactive?
Think back to the bouncers.
Right, what's the mechanism?
The answer is that the ayahuasca brew contains harmful alkaloids, which act as monoamine oxidase inhibitors, or MAOIs. These MAOIs prevent the rapid breakdown of DMT by the MAOA enzymes in the gut, allowing the DMT to cross into the bloodstream and reach the central nervous system.
Last one, question 6. Which subclass of hallucinogens is most likely to produce true hallucinations alongside severe disorientation, grossly impaired memory, flushed skin, and a fluctuating mental status?
Give it a second.
Okay, what is it?
The answer is anticholinergic deliriants, such as datura or scopolamine. Unlike classic hallucinogens which produce illusions with a clear sensorium, these agents induce a true medical delirium by blocking acetylcholine.
Brilliant. We highly advise you, the listener, to refer back to Chapter 11.6 in Kaplan and Sadox for a deeper review of these concepts. Here are the details of this episode.
Hallucinogen-related disorders.
Yep.
Byline. Not every altered reality is psychosis, but every altered reality demands careful understanding.